We have quite a different type of episode for you today, and although not directly about psychotherapy, today's topic is something that therapists frequently deal with in the consulting room. And throughout our conversation, my guest and I discuss the impact and implications for therapists. One of the ways that I identify podcast guests is that I stumble on something that I know nothing about, but I'd like to know more about. Then I run off to the internet and ask it, who are the top researchers in the world in this area? And so several months ago, I was in the middle of exercising and pondering various diet related things, and it hit me that while I know a lot about weight loss, I know absolutely nothing about weight loss maintenance. And it also hit me, I don't even think that I've ever heard anyone talk about weight loss maintenance in an informed way. So off to the internet I ran, and about 24 hours later, I hear back from today's guest, one of the top handful of researchers in the world on weight loss maintenance. He happened to be doing publicity for his forthcoming book on weight loss maintenance for people who have lost weight using GLP-1 medications, drugs like Ozempic. So, the conversation that you'll hear today is mostly about GLP-1 medications, how they work, considerations for taking them, etc. Honestly, I wasn't that interested in his topic before reading his book, but both his book and this part of our conversation was really fun, and I feel very differently about these drugs now. The conversation that you'll hear next week will be much more about weight loss maintenance, which, spoiler alert, is notably different from weight loss. But first, if you're new here, I'm your host, Dr. Dan Cox, a professor of counseling psychology at the University of British Columbia. Welcome to Psychotherapy and Applied Psychology, where I dive deep with leading researchers to uncover practical insights, pull back the curtain, and hopefully have a little bit of fun along the way. If you enjoy the show, do me a huge favor and subscribe on your podcast player, or if you're watching on YouTube, hit the like and subscribe button. It's one of the best ways to help us keep these conversations going. This episode starts with my guest responding to my question about how he got into studying weight loss maintenance. So without further ado, my very special guest, Dr. James Hill.
Well, I actually started out studying, how body weight's regulated. And when I was a graduate student and an early researcher, I was interested in why so many people maintain a constant weight across their life.
Right. Right.
All right. Fast forward. That doesn't happen anymore. So I was actually interested in the regulatory mechanisms because back in the 70s, when I went to graduate school, most people stayed the same weight throughout most of their life. And it was only later on that we realized the population was steadily gaining weight. But what really got me interested in weight loss maintenance was a project that I started in the early 90s with a very famous psychologist, Rena Wing. We started the National Weight Control Registry. And Dan, this is a project that literally started over a beer. We were at a meeting together and we went and had lunch, and yeah, maybe we had a adult beverage, and we were saying, you see in the media how nobody succeeds at weight loss and the people that do are weird and psychologically different. I wonder if that's true. And then we kind of realized that's not a bad idea. What would happen if we go out and try to find these people? So we did, and we started a registry of people that are successful. We didn't know if there were 2 people, 10 people, a million people out there. And over the years, we studied upwards of 10,000 people who had lost weight and kept it off over the long term. Really successful people.
And so I just want to jump back to something you just said. So you were saying when you went to graduate school in the 70s that people sort of maintained, right? So if they were
Yeah.
a little, like if they were on the slender side, if they were a little on the heavier side, that persisted, right? And right, which is something I think, but what you also said is that's not the case anymore.
Right, right. So it was where we recognized as a country that we had a problem was in the mid to late 1980s because the government does a survey called the National Health and Nutrition Examination Survey. They do it constantly now, but back then they did it every 3, 4, 5 years. And one of those came out in I think it was the mid 80s. And what it showed is, oh my gosh, the weight of the population has increased. There are more people who are gaining weight than there ever were before. That's kind of when the research community, the public health community realized, hey, wait a minute, this obesity thing is something we maybe should take seriously. Before then, not very many people cared about obesity, not very many people studied it. Uh, and since the 1980s, what we've realized is the weight of our country has gone up and up and up. It creeps up every year. And now we have enormously high rates of overweight and obesity. Back in the 1970s, what, not very much.
Huh. Uh, I'm assuming that shift is consistent across a number of, whether it's developed countries or Western countries. I'm assuming that's not just a U.S. thing.
Yeah, it is true. The timeline doesn't line up exactly, but it
Right.
lines up, pretty closely. So, sometime probably in the early 80s is when the rates of obesity started being noticeably higher. Now, you can say this is probably something that was happening under the surface all along. So it was only in the 80s that we started seeing that. So the iceberg is coming up to the surface gradually, but we don't see it, come above the surface until the 80s, and that's when we noticed that objectively we had numbers to show that obesity was increasing.
And is that slope sort of is that the trajectory of the slope, is that like consistent over the last several decades, or has that gotten steeper or
Great
shallower?
question. Great question. So, really, from the time we noticed, say the mid 1980s to 2000, is a really steep increase. Since 2000, it's been more of a gradual increase. So, you can think
Huh.
of two slopes, a very quick slope and then a much slower slope. The other thing that's happening is the data suggests that even though total obesity rates are going up very slowly, the weights within those are increasing. So we're in the category we would say are obese. Those weights are even higher. So that the category increases a little bit, but within the category, the average weight is even increasing. So the people that are heavier are getting even heavier.
And I was trying to remember, I can't remember if it was your podcast or if it was another one where I just heard something like that the folks who sort of fall in that obese category, like that the mean, the average weight gain across the population is not necessarily the best metric for conceptualizing what's
Exactly.
happening. Right. So that, and please correct me where I'm wrong, but kind of the idea is the slender-ish, I don't know if this, and also feel free to correct my language, the slender-ish folks are staying slender-ish, and the folks who are falling in the obese category, they're staying in that category, but but their weight is increasing. Is a terrible way to say it.
No, that's generally true, but so if you divide the population into um, say not overweight, overweight or obese, the obese category is increasing gradually. The overweight category is staying about the same, which means the not obese category is decreasing just a little too.
So you're saying that like the number of people in those three categories, that like the distribution slowly moving over, where folks who are
Slowly,
in,
yeah, you're exactly right. It's slowly moving from lean to obese, with that middle category, sort of the turnover category. People are entering from leanness to overweight at the same rate they're going from overweight to obese.
and okay, so because I think I could probably talk to you for days, not minutes. So I don't want to get too far off where I don't want to miss the target too much here. So just one more question on this, probably. Are we seeing these? I know the categories are slightly different, but are we seeing these changes also in kids?
Oh,
That Oh, okay, go for it.
yeah, it's even worse in kids. I mean, if there's something people should be upset over, it's the increased obesity in kids. Because again, going back to the 1970s, there was virtually no obesity in kids. You had a few kids that were overweight and chunky, and every now and then an obese kid. It was not an issue. While adult obesity has more than doubled in that time, childhood obesity has more than tripled. And we're still conservative about how we define childhood obesity. And what that has led to is now we're seeing type 2 diabetes, which is an adult disease in kids. I think I'm probably not exaggerating to say in the 1970s, there were 0 cases of type 2 diabetes in kids. Today, it's very, very frequent.
Wow. So
Totally preventable. Totally preventable.
you know what's amazing, Jim, is so I'm born in 81, right? So when I go back and watch, older media, or hell, even if I go back and look at pictures from when I was a kid, and you looked at, or you watch movies from the 80s, the quote unquote overweight kid was like what, like he or she was not really
Normal
that.
kids now, they're what you see on the playground all over. Yeah, I often, Dan, I tell people to do that. Go back and look at pictures from the 1930s and the 1940s. Even adults, they look emaciated. You have these skinny stick figures. And yeah, every now and then you see someone that's a little overweight and they stand out. And that's changed a lot today.
Yeah, and again, and I think, going again, just the 80s, like the 80s, and I mean, I guess that's partially because I'm getting older, but to me, the 80s was yesterday,
Yeah,
and it's just like you just look back at media from that time point, and it's like, wow, it has changed so much.
so
Um,
much.
so uh, this is a question. Here's the question. Okay, what's unhealthy about being overweight?
What's unhealthy about being overweight is and it's not really overweight, it's overfat. Okay, so you get the big guys with the extra muscles and everything. That's not unhealthy. What's unhealthy is when you get higher amounts of body fat. Okay, where some body fat is good, body fat is useful, but when you get too much, there are a couple reasons we're concerned, but one of the major reasons is the extra fat basically interferes with your metabolism. It causes you to be resistant to insulin, it causes inflammation, and leads to all the chronic diseases, diabetes, heart disease, kidney disease, etc. Much of those diseases can be traced back to having too much fat, which interferes with metabolic processes in a way that they aren't functioning well. You're resistant to insulin, you develop diabetes, you have more fat in your blood, you develop heart disease, your kidneys don't function as well, you develop kidney disease. So the excess body fat leads to metabolic derangements.
Hmm.
It also leads to problems of arthritis and joint overload, knee replacements, hip replacements, gynecological problems. Just about every system you look at is negatively affected by having excess body fat.
So I think about it, and tell me if I'm wrong here, but that like there'd be few physical uh, problems, for lack of a better word, that aren't correlated with being overweight. That is just a generic baseline, is just associated with all sorts of negative physical
Yes.
outcomes.
Yeah. And again, let me say that there are exceptions. So there are some obese people with obesity who don't have metabolic derangements, but the majority do. If, we can predict pretty well from your excess body fat your risk of developing some of these chronic diseases. Not everybody will do it, but the risk is much, much higher. If there were no obesity, type 2 diabetes would be a rare condition.
So it's sort of like smoking in that, everybody has those anecdotes of their 95-year-old grandmom
That's
who,
right.
smoked 2 packs a day and was totally fine.
Right.
And, but we all know it's just ridiculously obvious that smoking, the probability of cancer and all sorts of other negative things.
Totally a probability thing. Excess body fatness gives you a higher probability of developing some chronic disease than not having excess body fat.
Got it. Okay. So we want to get into talking about GLP-1s.
Yeah.
I want to spend a few minutes just sort of talking about that broadly. And obviously, I think at least the one that's in the media the most is Ozempic.
Yep.
Um, how did GLP-1s work?
Yeah. So let me start by saying these drugs have revolutionized how we think about obesity. I can't emphasize enough what a breakthrough, a disruption, I say a positive disruption in our field, these drugs have done. So, the way they work is researchers discovered that there are signals from the GI tract that go to the brain and affect food intake. Okay. These are GLP-1. Okay. That happens naturally. So naturally, your gut is telling your brain something about the amount of food there. What these drugs do is they mimic the effects of this natural GLP-1, but they're much more effective. So they hit these brain receptors that your natural GLP-1s would hit, but number one, they stay around longer. So naturally, when your gut elicits GLP-1, it goes to a brain receptor. It may stay there only a short period of time. These drugs stay there longer, so they really have an enhanced effect on reducing your desire for food. And that's essentially what they do. They do some other things. They slow gastric emptying, which also seems to contribute to you not needing as much food to feel full. They shut off what people talk about food noise, always thinking about food, etc. But the major thing they do is to make you happy eating far less food than you were eating before. That produces significant weight loss in most people.
And in the book, you talk about food noise, which I'd never sort of heard that phrase before, but I felt it was a really helpful phrase because often you think about people we eat often when we're not super hungry, right? And so that the sort of food noise to me in some ways is that sort of gets caught up in there, and that these GLP-1s, it's not just that it's I could see, oh, feeling less hungry, but will I still eat more because that's what I do? That's my coping mechanism or whatever. But it also seems to be effective, at least in many cases, in terms of damping that down, where that feeling, that desire, that maladaptive coping mechanism even kind of abates.
Yeah, this whole term food noise, it's actually a new term. I hadn't heard it probably much before a year or so ago. But I got to tell you, it connects with people. If you've experienced this and you hear the term food noise, it's explained to you, you get it right away. So many people said, oh my God, that's exactly it. It's like a radio's always on about food, eat all the time. And for whatever reason, and we don't know how, these drugs tend to shut that down. And people will say, for the first time ever, I don't hear this food noise. Now, one of my colleagues here said, what we need is a pill that people who have never experienced food noise can take and see what it's like to experience food noise. So if you haven't experienced it, it's a little hard to understand, but if you've experienced it, these people know when you explain food noise to them, they get it. They say, that's it. And so one of the big things that people report on the GLP-1 based medications, the food noise goes away. Now, I think it's going to be fascinating for researchers to figure out what is that? Where does the food noise come from? How are the meds shutting it off? fascinating science to figure out why. But the long and short of it is the decrease in food noise is one of the big benefits that patients report taking the meds.
Hmm. So, if folks are, uh, who do you think should, strongly consider taking GLP-1s?
So, I guess the thing is, who shouldn't take GLP-1s? And there are very few. No, to say who wouldn't qualify. The choice to do it is a different one. It's not approved for pregnancy. It's not approved for young kids, certain types of thyroid problems. But really, I mean, you never know what you don't know, but it's proven to be surprisingly safe. Most people who take these get some side effects. They're mostly GI side effects, the kind of GI side effects you would expect: nausea, vomiting, diarrhea, some of that. In most cases, they're fairly mild and fairly transient. There are examples of where some people just can't tolerate the side effects, and that's one reason a lot of people discontinue the meds. But they've turned out to be surprisingly safe. And so the decision to take them, I think, becomes a personal decision, or certainly a decision you want to talk to your healthcare provider about. And it really relates to, how how big a deal is weight loss in your life? There are some people that are overweight and they're perfectly happy, and health wise they're okay, etc. But if you're having health issues, or if losing weight is such a big deal for you, it may be worth considering taking these.
So there's no, like, obviously what you're saying. I mean, I feel like, we should put up the quick, sticker of, talk to your physician and all that stuff. But that aside, and sort of those couple of caveats aside, uh, are there any, I don't know, life situations, psychological profiles, anything that where you see like, yeah, maybe this isn't so helpful for these people, or maybe this is like, in terms of those considerations of what folks should, if this will work for people, or if this is a good idea for people or not.
Yeah, we always worry about the psychological aspects, and some of the previous medications that have been developed for weight loss tend to maybe have some negative psychological effects. One medication, more suicide ideation, etc. We haven't seen any of that with this medication. Now, we've been developing medications for a long, long time, and most of them have either been not sufficiently safe or not sufficiently effective. But one of the things that we benefited from is we kind of know where to look for problems now. Some drugs have had heart problems, some have had psychology problems, etc. So the good news is, for this round of drugs, they've looked at all that. And so far, we haven't found any major watchouts. Now, we don't know what's going to happen down the road, but right now, these things have turned out to be pretty darn safe.
Do you think that, and we're going to talk about sort of obviously getting off of the drugs, which is a lot of where your book comes in. Um, is there anything wrong with staying on the drugs long term?
Absolutely not. And that's one of the things that we talk about in our book. Our book was written for people who cannot or decide not to continue the meds. But we say right up front, if you take the meds, if they work for you, if you're feeling good, if you tolerate the side effects and you want to stay on them forever, that's okay. The other thing is, you don't have to decide forever right now. You can say, look, my strategy is to go long term. You can always change that. Just like if you go off the medications, you can always go back on them. So one of the things we want people to understand, you have some options, and your job is to figure out the option for you. One option is going on the meds, staying on the meds long term. We do that for diabetes medication, blood pressure medication, heart medication, lots of medications that people take and plan on basically taking the rest of their life. If it works for you, that's a very, very viable option.
It was interesting in the book, you talk about some of the reasons that people decide to get off of the medications, one of which is the obvious one, which is side effects. But you talk about some other ones that I'd never thought of before. So, what are some of the reasons why people decide to get off of the drugs?
And again, as we're talking to these people, we heard ones that we wouldn't have anticipated, so we were surprised. The two big ones, side effects and not covered by insurance. These drugs are very expensive. And we hear lots of stories of, I went on these drugs, my insurance paid for them, went along just fine. My insurance decided they weren't going to cover them now, and I can't afford to do it. Those are the two big ones. But there are other reasons too. One of the most interesting ones um, that I have come to understand is people actually miss food. If you think about it, we food serves many more functions than just nutrients for us. So, I one of the things I dearly love, I love going out to dinner with friends and having parties and dinner parties and everything. Well, a lot of people on these medications, it's like, I don't want to go out to eat because I just don't want any food. Nothing seems good. And, that affects everybody else. And so there's that aspect of it. And again, we're not making any judgments here. If that's something that impacts your quality of life, that's a very, very fair reason to say, I want to go off them. Another one is you still have a lot of people who feel like they shouldn't need a drug to be able to manage their weight. And they're okay to say, I'll do it as a short term tool. I'm not comfortable thinking about taking a drug forever to do this. Another one, people that want to get pregnant, they say, right now it's not recommended. It's not that we know it's bad, it's just that there are no research studies that are done. So we don't know. So cautiously, we're not recommending that. So
Yeah, what
those
you
are
said
some of the big reasons.
what you said at the in your book, if my memory serves, I feel like it was a couple, but I could be misremembering, who were maybe both on the drug. I don't remember, but that it was their social life was very much based on having dinner
Yeah,
parties or going
yeah,
out to dinner with
exactly.
friends. And I was just sort of like, as I read that, it was one of those times where I sort of put the book down and just sort of, wow, that's, because you don't think, you think like, oh, well, I'm a little less hungry, but I can still go do these things. But if it's so if the drug impacts your system so much that food is just totally undesirable, that's going to, I just thought it was just blew my mind. I
Yeah,
never thought
and
about it.
think about it. And so you're out to dinner with somebody like that, and that sort of influences the whole thing. And they're not gonna, food doesn't taste good to them. It kind of, you can see socially, you can see where that would have an impact. And many people revolve a lot of their social life around food.
Yeah. Yeah, of course. So one of the other things you said, which is people just not wanting to, or not feeling kind of okay with staying on the drug long term. So I don't know if you've watched, but there's a recent Netflix documentary about The Biggest Loser, the TV show.
I purposely not watched it because I know it's going to make me angry.
Got it. Got it. So they had
I'll
a
probably
gentleman.
watch it.
Yeah. So I watched it, but they had a guy on there who had lost a lot of weight and gained it back. And so this was as I was sort of reading your book and thinking about all these things a lot. So the timing was kind of perfect for me. And one of the things he talked about the GLP-1s, and he said something like, I just don't feel right about taking the drug,
Yeah,
or,
yeah.
it feels like cheating or something like that. So how do you, what would you say to folks like that?
We actually have a little blurb in the book that basically says it is not cheating. What these drugs really demonstrate clearly is keeping losing weight, keeping weight off is not just willpower. It's more than willpower, because you have people who have tried for years to use willpower alone and failed. Now they fix the biology and they succeed. So we talk about it. Do not feel it's cheating. In fact, it's leveling the playing field. You were at a disadvantage because of your biology. Now the medications fix that. So don't feel bad about that. You're simply now leveling the playing field.
So for, a lot of my listeners, or most of them, are either therapists or therapists in training. And so these are conversations that are going to be coming up in the therapy room about people who are considering taking these medications. In thinking about therapists talking to clients, and obviously the therapists, they're not experts in the biology, the physiology of it, or any of that sort of thing, but how do you think that they could help people think through their decision making around taking these medications?
Oh, I think they play such a critical role, and I'm glad that we have a chance to talk to them. What I've started asking a lot of people who start the GLP meds, what's your long term plan? You know the number one answer? They hadn't thought about it. All
Mm-hmm.
they're thinking about is getting the weight off. And that's the way weight management has worked for decades and decades. People never get beyond getting the weight off. With these medications, what we find is people can actually reach or nearly reach their goal weight. So the question is, can you can you help people by having them think early on what's your long-term plan? So let's do an example here. Let's say you come to me and you're prescribed a GLP-1 med, and I'm saying, Dan, this med is going to help you reach or nearly reach your goal weight in maybe a year. What are you going to do then? Is your plan to stay on it forever? Is your plan to figure it out later on, see how you feel? What's your plan? Okay? And I think you've got three big uh, options here. One, you can stay on it forever. Okay, the therapist there are a lot of things we can do to improve health. So you take the drug, you're going to stay on it forever. So the drug's doing your weight, but it's not doing other aspects of your health or your mental health. One of the things I worry about is you don't have to exercise to lose weight on these meds. And I think exercise provides so many other things. You don't have to have what we call in the book a healthy mind state to keep the weight off. But you do have to exercise and have a healthy mind state in order to maximize the benefit on your quality of life of the weight loss. So there are things you can do to help. Drugs are doing the heavy lifting on the weight. Therapists can work for other aspects, particularly the mind state part. Another option is to lose weight on the meds and then say, I'm going to keep it off with lifestyle. One of the things we know is unless you have a strong plan, you're going to regain it. Now, it's pretty interesting. You talk about these people on the meds. So many of them have told me while they're taking the meds, they say, no problem. I can stop the meds. I got it. Everything's going to be okay. Boom. They stop the meds. The hunger comes back. The food noise comes back. The weight comes back. That's why we wrote our book, to say, look, you don't have to regain the weight if you stop the meds, but you do have to have a strong plan. And then the third possibility that I think we're going to see more and more is people going off the drugs on lifestyle and using the drugs either intermittently at low doses, etc., a combination of focusing on lifestyle and medication. I think all three are viable choices. Any one you choose is okay. And you can change that. You may say, I want to do it forever. You may decide no. You may want to go to lifestyle, decide you'd rather do the drugs. One of the things we really emphasize, everybody's different and there's no one way for you. You have different options.
Mm-hmm. So is it the case that if you that you can manipulate the dose, and that your hunger will, that it'll go up and down like a slider? Is it that sort of continuous?
That's where we need the research, Dan.
Got it.
The hope
Okay.
is that we can figure that out. The problem is, and keep in mind, these drugs are still early on in how we use them, etc. So what I think you're going to see over the next few years is some very exciting research. Does lower dose work? Does intermittent use? Is it a rescue strategy? While everything's going great on lifestyle, it's fine. When it's not, you go back on drugs. We just don't have any data, but the potential options are really exciting there.
So, if you're a patient or if you're a therapist who has patients and you want to find somebody in your community who really has a GP in your community who really has or a nurse practitioner or whatever, who really has some expertise on this stuff. Because the reality is that most physicians can't have expertise on everything, right? And so but you want to find somebody who really knows what they're talking about to refer patients to, or you're the patient yourself and you want to talk. Like, how would somebody go about finding somebody in their community, who really would be, have some expertise on this to talk to?
That's a really great question. And I'm going to give you one example. I have a relative, I'm not going to mention any names here, who's very overweight. And, you know, with relatives, you have to be careful about bringing this up. So I've never brought it up. I've always thought the drugs could be an option. What I found out, I had nothing to do with this. I found out this person went on the meds, had horrible side effects, and basically said, that's it, I'm not doing it. Well, they were probably prescribed by a physician that didn't know exactly how to do it. Because if you were having terrible side effects, you back it up, you take
Mm-hmm.
low doses, you start. So, this is part of the problem. There are physicians who know what they're doing with weight management and they're fantastic. There are other physicians that prescribe it just like they would prescribe another drug. Here's your drug, go out and come back in 6 months. Lots of people need some help doing that. The question is, who is there to help? First place I would start is with a registered dietitian. They are really getting very involved in this, and there are registered dietitians in every community. What they can do is a couple of things. One is they can help you manage the side effects. There are things you can do on the diet side that can reduce the nausea, etc. They can make sure you get enough nutrition. One of the problems with these meds, people are eating sufficiently little that they're actually nutrient deprived. So a dietitian can help with side effects. They can help making sure you're getting the right kind of food. We think higher protein is particularly useful for these meds, so they can help get enough protein in your diet. So that's one place to start. Another place to start, I'm not sure how this community is ramping up here, but on the exercise side, you need people who can work with you while you're on the meds to say, look, you don't have to exercise to lose weight, but exercise is going to do so many other positive things for you. And to take into account, I think the fact that people are losing weight is a great opportunity to get them started on some of the exercise stuff. And then the third group would be the therapists, because the drugs don't affect your mind state, and I hope we can talk more about that
Mm-hmm.
in the future. And that's particularly important whether you want to stay on the drugs or go off the drugs. So dietitians are out there, and they're pretty up on this problem. Exercise people, check around, talk to people who can understand how to do that. And therapists, I think, are going to be critical in all this.
One of the things that I was thinking about is that there are probably a lot of folks who want to talk about this with their health provider, but feel embarrassed to, or they're worried that they're going to bring it up and their physician is going to be like, no, 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 like, no, we don't do that, or something that's going to sort of, do you have any thoughts for those folks?
Yeah. We actually did a whole episode of our podcast on that. We had a good friend of mine, a physician, Dan Bessison, who we did a whole podcast on how to talk to your physician about this. And it's complicated. Number one, we need the physicians to be better about this. So physicians should be aware of it. So you shouldn't be made to feel ashamed or you shouldn't be made to feel that you have to do it. But you should be having those conversations in a non threatening way with your healthcare provider because they can help guide you. So you say, who should go on these meds? Your healthcare provider should help you decide if it's the right thing for you. Now more than ever, we have multiple tools to help with weight management. These are one tool, they're an important tool, but there are other tools. So this is why your healthcare professional should be in a position to help recommend the right tools for you. And so Dan, if I remember in the podcast, basically said, as a first step, try talking to your physician, try bringing it up, try this and that. And at the end of the day, you might have to see another physician. There are plenty of people out there who can do it. But he was very adamant. Try with your current physician. If you have a good relationship with your physician, try working on that. But at the end of the day, if you feel like you're not being taken seriously, um, find someone that will take you more seriously.
That's wonderful. And what I'll do is I'll link to that episode in the show notes for anyone who's
Okay.
listening, that they can just go and listen to that. That's wonderful. So, what's it like? What's the experience like for people when they stop taking the meds?
So people are totally freaking out by stopping the meds because think about it. You've experienced food noise for 30 years. Now it's gone away. And you're saying, if I stop the drugs, it's going to come back. That would make me a little nervous. You're saying, I've never before been able to look at a donut and not eat it. Now I look at it, I don't even want it. I'm afraid of having to do that again. And so there's a reason because when the meds only work when you take them. When you stop taking them, the benefits of the meds go away. Now, maybe the good news on the GLP-1 meds, they don't go away right away. They actually stay in your system a while. So you have a little bit of a runway. But what we try to tell people in the book is anticipate it. So we talk about the appetite, finding the right appetite set point. While you were overweight, you're probably eating too much.
Mhm.
While you're on the meds, you're eating too little. So, can we help you find an in between? If you go back to the appetite you had before, we know what's going to happen. It's unrealistic to think your appetite is still going to go low. So we want to help you find that right spot where your appetite is lower than it was before, but higher on the meds. Okay. How do you balance that? Well, you balance that on the activity side. If you're going to eat more, you've got to exercise more to keep from gaining weight. And that's why people who focus on one solution, food's the solution, exercise is the solution, mental health solution, it only works if all three are paired together. So with a good plan, you can eat more, increase your exercise, improve your mindset, and maintain your weight.
Thanks so much for watching. If you found it helpful, please like the video and subscribe to the channel. I'll see you in the next video where we continue exploring the science of psychotherapy and applied psychology.